for this special call meeting to the HR committee. I've been told that everyone's registered already, so we're going to go straight into the emergency message. In the event of the emergency evacuation, an alarm may sound. Everyone should exit the building by way of the nearest stairwell in a safe and efficient manner. If the nearest stairwell is blocked by smoke, use the other stairwell. Do not use the elevator. Once we reach the main floor, follow the exit signs and exit the building as quickly as possible away from the building. Please be mindful of other evacuation and emergency vehicles. Chair would entertain a motion to set the agenda. Who was that? Mr. Brown? Mr. Lewis? Okay. Okay, let me find the, I see it. Mayor?
Mr. Chair, I would like to make a motion to add 2 items to this agenda before we vote to set it, adding a new item number 5 and an item number 6. These 2 items are critical for the HR director and her staff to prepare for our open enrollment for the county employees this year. These items have usually been addressed and are to the commission by now, so time is of the essence. And these items are item 5 would be discussion and possible action on adopting the medical rates effective 1/1/19 to prepare for open enrollment, and item 6, discussion and possible action on adopting the new dental rates effective 1/1/19 to also prepare for open enrollment.
Okay, we've got a second. Does anyone have a question about the addition to the agenda? Members ready for the question? Okay, the motion is to approve. Help me, I don't, okay. Wait a minute, okay, I'm sorry guys, I didn't write it down. To the action to set the medical rates, and 6 would be the action to adopt dental rates. Okay. Okay, we're waiting just a second here. Probably need to.
It'll be 2 amendments, 5 and 6.
Yeah, 5 and 6. Okay. Somebody got any questions, discussion? Okay. Please vote yes to add these 2 to the agenda, no not to add them. Sorry.
Yeah, I'll fix it later. No, no.
Okay, passes. So we've got 6 items to look at this morning, or this afternoon. I guess I really did, I skipped a I probably need to back up here and see if there's anyone in the audience that wants to speak to the items that's on the agenda. I see none. Yep. Number 1. Yes. Who's this? Michael?
I move that we combine new business items 1, 2, and 3 and move all 3 together.
I'm getting ready.
Well, okay, when we
Wait
get
till I
there,
get
that's
to
my
D.
motion. When we
There you
get there,
go.
that's my motion. How's that?
Yeah, okay. I need to do the minutes first. Okay. C, I entertain a motion to approve the minutes from May the 21st. I need a motion. Who?
Click it. Did you make the motion? And then whoever seconded it. It's not showing.
Okay. Any discussions on the minutes? If your members are ready for the question, vote yes to approve and no to disapprove of the minutes. Mm-hmm. 10 yes votes. Now, Mike, we're looking at D1.
Yes, Mr. Chairman, I apologize for jumping ahead. I move that we combine new business items D, 1, 2, and 3 and move together as they have already been discussed.
Okay. Do you, what about 4? Okay, okay. Got a second to combine 1, 2, and 3? Okay, got a second there. Any discussion?
Wait a second. I'll change it later. I don't know why it didn't do it on there, but I've got it.
Okay.
1 through 3.
But they've still got a motion and second, huh?
Now, we're voting on to combine these.
Okay, so who was the mover?
That might be Mr. Baylor and Sheriff Brown. Was the second. Now we're voting.
Your vote.
Ready for me?
No, it's not working.
Will,
Was that it?
yes.
Yeah, that's fine.
The motion is to combine D1, 2, and 3. Are the members ready for the question? Okay, roll call, please.
Commissioner Caskey? Sheriff Brown? Mr. Brett? Commissioner Carver? Commissioner Taylor?
Yes.
Phyllis Crisp? Yes. Scott Graves?
Yes.
Jeff Hedrick?
Yes.
Mike Lewis?
Yes.
Mayor Mitchell?
Yes.
David Merle?
Yes.
Tom Stinnett?
Yes. Okay. Now, the motion is, what we need to look at now is these 3 very quickly. That we spoke about these during the presentation on April the 17th. One of them's on the background check, number one, and what it's about the contract has been returned and ready to go, and it's been looked at by the lawyer, and we're ready. All we have to do is move this to the commission. The other one's the volunteer benefit vendor, U.S. Able, number two, and number three is with U.S. Able 2, it's the hospital entity protection. Is there anyone got questions or discussion about these three? Members are ready for the question. Vote yes to move those to the commission, and vote no not to. Need a divorce. Did I skip that part?
Yes.
Oh, okay. Mayor's made a motion to move it to the commission. I need a second. Sorry, guys. Mr. Carver. Now, if there's no questions, we'll take a, okay. Vote yes to move this to the commission. Vote no to return it back to this committee. 10 yes votes. Item 4 is to consider the discussion that began in May the 21st special called meeting. Oh, I'm sorry, 3, excuse me. Chair, we're entertaining a motion for item 3, discussion and possible action regarding the addition of the hospital entity.
No, we 1 through 3 we already put together.
Oh, 4, I'm sorry. Gee whiz, guys.
I know. I'm confused too.
Yeah. Okay, now, guys, we don't want to do, I guess, we're going to do 4, okay? Well, item 4, excuse me. So we can get to you guys. Sorry about the confusion here. Item 4 is the continue discussion that we started on May the 21st, special call meeting regarding the local pharmacies concerning their reimbursement. So what I'd like to do is start here with Phil and Aaron. Introduce yourself, give us the basic, catch us up to where we was at when we quit on May the 21st, and then we'll come to this table. Okay, Phil, and let me see if I can, there you go. I've got your mic on.
It's not working out here.
There you go.
Okay.
Okay. I'm Phil LaFoy. I'm co-owner of Blount Discount Pharmacy here in Maryville and Alcoa. We have 3 retail operations and 1 closed-door long-term care pharmacy over in Alcoa. This is my business partner, co-owner Aaron Clark. He's also a pharmacist and works in our business. Some of you weren't here, so I'll bring you up to speed as quickly as I can. We have some concerns which surfaced last fall. I went to the mayor about it, I think, in December, and started trying to raise some awareness in that the reimbursement we were receiving from on the Blount County Employee Prescription Program had dropped significantly. We were seeing it trend downward from back in last summer. Late October, reimbursements plummeted. And the sheets that I gave you, you'll see I've built a chart there and broken down by month. And as we saw reimbursement drop, as you see the first graph there, I've got number 2. That's the cost of medication to us per month across since July up until current. We've seen the cost of medication go anywhere from about $51 up to about $61 on average per prescription. So as the cost of purchase medication has stayed fairly consistent, we've seen the amount of money we're being paid to fill these prescriptions trend consistently in a downward spiral. So we've had some real concerns about this, so much so, if you see back up to the top chart, and right in the middle of the chart where it says profit per RX, if you look at the bottom of that column, it says minus 0.085. That's what we've been paid per prescription since July. So 11,781 prescriptions, and we've been paid minus 88.5 cents per prescription. When you take into consideration the cost, the hands and the overhead it takes to fill a prescription, it costs us about $13 to fill a prescription. So since July, our company has lost over $150,000 on the Blount County employee drug plan. I have a real problem with that. I have a problem with that as a local businessman. I've heard the mayor speak at different small business events, and he says, we're for small business in Blount County. We support small business in Blount County. Well, Blount County is well on the way of putting this small business out of business if this stays the same. We're faced now, at the very least, we've got to lay people off because we don't have $150,000 to give. We've tried to take a big picture approach, and we've tried to heighten awareness, and which is what we're doing now, and I'm hoping we can get some help on this thing because this is not right. This is not right. So a couple of things just to bring to your attention that I didn't get to talk to when we came before. If you look on the bottom there at number 3, and this is a question that I like to pose, alluded to with Mike when we were eating lunch. 54.8% of the prescriptions we fill are what we call zero balance claims. That means CVS Caremark pays us nothing. So we get whatever the co-payment is that's established to the patient, that's all we get. My question, so that's 2,337 prescriptions. My question to you, because I don't know what kind of detail you get from a human resources standpoint. I don't know what kind of detail CBIZ gets. At the claim level, what are you being charged for those prescriptions that I'm being paid nothing on? I'm asking that question as a concerned citizen of Blount County that happens to have a little more information than the standard citizen. I want to know how much of my tax money is being paid against claims that nothing is being paid on. I think that's a valid question that you should ask and you should get an answer to, and I can assure you, you're going to have a hard time getting that answer. One of the questions that came up when we were here before was, no, this is not just a CVS Caremark issue, this is a national issue, but in this particular case, as we've seen the reimbursements trending downward, the industry people I've talked to have looked at the Blount County employee plan as being one of the most poorly reimbursed plans anywhere. So I did some research in our stores, and this is nothing proprietary, I'm not giving you anybody's information, but if you see that box that says number 4 on the lower right, these are other plans that are billed through CVS Caremark, and this is the gross profit per prescription we receive from other plans in the region. And this goes up against your minus 0.085. Something's wrong. Something's bad wrong. And this has got to be addressed. The lady asked me last week, what is your answer? What is your solution? Well, I said, we have to find somebody else to do business with. Well, this right here shows us somebody out there, CVS, is doing decent business with folks. So this is not a complete beat-up CVS meeting, but if they're going to continue to practice and pay us minus 8 cents a claim, then we need to get rid of CVS and find somebody that's going to pay us to provide the care that we provide for you folks and for your families and across the county. I mean, they have the numbers. They can tell you we fill the majority of the prescriptions for the employees and their families of Blount County. And that's going to be pretty bad when we're not here to fill them, and you have one less choice to make of where you can go to get your prescriptions filled. This is not a Blount Discount Pharmacy situation. This is a city drug situation. This is a Lowe's pharmacy situation. We're all seeing these things. And I don't know, the chains, I don't talk to those folks, and I don't know what their numbers are looking like, but I have had this discussion with City and Lowe's, and we're all seeing the same things. And this is putting a huge amount of pressure on our business, and I don't think it should be.
Cole, would you like to introduce your people and y'all respond,
Yeah,
please?
happy to. Thank you. Thank you, Commissioner. Can you all hear me? Okay, perfect. So my name is Cole Harris. I'm over the CBiz Benefits and Insurance Work Considered Broker, who was selected back in 2015 to handle your benefits package. I've got to the left of me Carrie Presley, who's your lead account executive that works in the day-to-day minutia with Jenny and Jody on the services of your plan and implementation through carrier transition. To the right of me, I have Mike Zuccarelli, who's from he's our Farm D with CBiz. He is a licensed pharmacist and has practiced in pharmacy and has a wealth of knowledge and information. He comes from our Arizona office, who we use as our consultant when reviewing any PBM contracts. He is our expert. And then to the right of Mike is going to be Kelly DiNardo, who is over with Employers Health, which is your purchasing group for what you pick up your Caremark contract through, which allows you to have some really good provisions within your contract. Add a few comments, if you don't mind. I'd like to go through, and then we'll also have some questions towards Blount Discount. And then I'll let Mike be able to respond to any specific questions you all have. When we were contracted over with Blount County back in 2015 to take over your benefits package, we handled that RFP process for the 2016 plan year under the assumption that Blount County is our client. So that's the way we handled the RFP process, is to ensure that we got you the best discounts and savings that we could find for your plan. And I think that we've been able to achieve that. I'm going to give you the per member per month cost after rebates with the prescription plan. In 2014, you all paid $98.56 per member per month. So this completely neutralizes any kind of enrollment change, and that's just for your pharmacy. So what that means is for every member on your health plan, you all paid $98.56 per month for your prescription program. That was in 2014. In 2015, that number went to $100.96 per member per month. So your natural pharmacy trend is typically, and you all can correct me if I'm wrong, anywhere from 4 to 6%, right? So that aligns with what normal pharmacy trend is. When we moved you from Humana in 2016, so again, keep in mind your 2015 per member per month cost was $100.96. And whenever you consider you all had around 3,800 members, that adds up quite a bit. In 2016, that per member per month after rebate dropped to $85.81 after moving to CVS Caremark as your PBM manager. So that is not only lower than 2015, but that's lower than 2014. In 2017, that number, without even considering the rebate reconciliations, which hasn't come through yet, but that number is at $92.35, which is still less than 2014. If you stack up all the other employers in your area and ask them if their pharmacy costs have actually gone down since 2014, I think you'll find that that answer is probably not going to be the case. So whenever we looked at the RFP, I think we did a great job of finding a vendor that was able to reduce costs, which was a big concern at the time, without hindering the performance to your employees. You'll find that your employees are able to get pretty much the pharmacy card, and the formulary is about the same as where it was before, is the most open formulary that CVS Caremark has to offer, whereas many of the other vendors, when looking at the RFP bid, was actually stating that the employees would have to steer towards other drugs, not drugs that their doctors prescribed them, but drugs that the PBM felt like would save you more money. So keep that in mind whenever you hear other PBMs saying they can save you a ton of money. CVS Caremark has those formularies as well, but Blount County has chosen to keep it to where the employees have the ability to keep their prescriptions, which was the number one concern by the mayor and the administration, to make sure the employees weren't told what prescription they had to get. So that's something I think is very important. Another part that I'd like to ask, and also Mr. Zuccarelli next to me has a picture of showing how the whole PBM process works, which I think would be advantageous for the committee to understand on both sides of it, of the costs. And to Mr. LaFoy's point, we are privy to only so much information. There's some information that we don't have access to due to their direct contracts. So Blount Discount has a contract with CVS. We're not going to see the details of their contract with CVS, just like we're not going to see what Lowe's contract is, nor CVS's with Caremark, which are two separate entities underneath a parent group. So the data that we have is just what the costs are towards Blount County for each of those. So we're not going to see what their reimbursement rates are, as that's going to be proprietary data. From my knowledge in the industry, and Mike by far knows way more and probably blinks more information than I have in my head on this, but from what I understand, just from my knowledge, whenever you're in a purchasing arrangement on the PBMs or on the pharmacy side, every time they have an acquisition of a drug, typically the wholesaler that they go through to pick up that drug will provide a rebate during that acquisition. So one of my questions might be, is this information including the rebates that you all receive on the acquisition side, so that when we're looking at overall costs, the costs that you get the zero reimbursement on, do you also receive rebates from the wholesaler? And there are wholesalers that do provide rebates. There may be instances where there's not, but to get the full picture, that may be important. Also, I think our data, and this could be due to time periods, but they're off, and it seems like this could be a significant number. On the data here, it shows an RX count of 11,781 over a 12-month period. Now, our date ranges are going to be different, but it shouldn't differ this dramatically. Our counts show that there were 16,000 drugs reimbursed or billed at Blount Discount from their pharmacies collectively. So while there might be a difference due to date range, that's 25-30% difference. So I question whether where the data marks might be a little bit off on that part. Also, from my limited understanding in the industry, I liken it, and this may be a poor analogy, but I liken it to the gas station business, that the majority of gas station owners will tell you that they lose money every time someone fills up with a tank of gas. Where they make their profit margins are going to be the front of the stores. So if Blount Discount were to remove Blount County from their program, which contractually, my understanding is they couldn't just pick out Blount County and remove it, you'd have to remove all of CVS Caremark from your clients, which would be significant, as many employers have CVS Caremark. But if you were to remove just Blount County from there, how much would you actually lose in revenue from the toilet paper that was bought at your stores, the candy bars, and the other items that typically have higher profit margins? And with having 16,000 drugs filled, or even in your case 11,000 from your data, that would seem to be significant. So when you look at an aggregate, and that's really how the PBMs work, is you're going to lose some on some drugs and you're going to win some on others. And to that point, that would be more of on Mike's side. I won't monopolize the conversation, so I'll stop there. Yep.
Okay. Sure. First of all, the script count, we run the reports through mid-May, to show those numbers. We ran the 3 retail stores. We did not show what we run through the specialty store and long-term care. So that might be some of the discrepancy you're showing there.
Okay, thank
But
you.
I don't know that it's that much, but we did run through May. As far as rebates go, we received a small rebate based on volume. It's about when you look at the book of business here, you're looking at about 80% of the dollars are for brand name drugs, roughly 20% are generics. There are no rebates. The 80% of the dollars are after rebate. So only 20% of the dollars reflected in these numbers are rebatable, and they only run about a 20 to 25% rebate. I can do the math for you if you'd like, but it's not a significant amount of money to any stretch. We do dead net on brand products, so very little rebate to be reflected in that. As far as the front end goes, our pharmacy runs roughly a 2%. 2% of our total book of business is front end. So for us to make up the difference, we don't have a loss leader front end. We're more of a healthcare facility. I don't run a big front end at all. It's all pharmacy driven. So when we take a hit like this on pharmacy, it's significant.
Do you want to talk about some of the CVS side? Sure. And then also on the rebate, as you mentioned, yes, just like you all, you're not receiving rebates on the generics, you're receiving on brand name drugs. To give you perspective, whenever we moved to CVS, your rebates went from...
Sorry, not to interrupt. Let me correct you. I'm receiving discounts on brand, but it's all reflected in these numbers. The generic is, I do get rebates on generic drugs, but it's after a purchase and it's about 20%, and it's not reflected here.
Okay, but the brand is...
The brand is after rebate dollars.
Okay.
Or after discounts, if you will.
Got it. Okay, that makes
So
sense.
there's a few dollars, but nothing of significance here.
Okay. You mention anything?
Yeah, so there were a couple topics that I wanted to walk through, and certainly keep this a dialogue, so Bill and your team, if you have any questions as we go along here, let's keep it open. I'd like to first start by saying, as Cole mentioned, I am a pharmacist. I empathize deeply with Mr. LaFoy's position that he's in, but want to paint kind of a broader picture of what this market looks like. Do you mind if we open up the PowerPoint?
Blount meeting,
The one that's in the background there.
the very, yeah.
Perfect. For those that don't have a handout, I apologize. Can the folks in front of computers see this pretty decently?
Can you do the view full screen? There you go.
So a lot of the issues that Mr. LaFoy has mentioned, these are national issues. This isn't something that's specific to Blount County, specific to Blount Discount Pharmacy, CVS. This is something that we're seeing nationally. What you see up here in front of you is a very simplistic view of what the drug supply chain looks like in our country. It's not perfect, it's flawed. Our administration at the federal level is dealing with this. This is the simplistic view. Let's go ahead and move to the next slide. It's the same exhibit, but now we have some colored boxes here with names so we understand the players. At the very top in the industrial-looking building, that is the pharmaceutical manufacturer. That's where our drugs come from. Over to the right in the orange box, that's our pharmacy benefit manager. In this case, that's CVS for the county. Down at the middle bottom in the pink box, this would be any retail pharmacy. It could be Blount Discount, Lowe's, CVS, Walgreens, you name it. These are the pharmacies that are actually providing the drug. In the blue boxes, there's two of them, Blount County, the entity, the fund, and then down at the bottom, essentially Blount County's members using those pharmacies. You'll notice that CVS, the PBM, and I'll avoid some comments here in the public sector, but agree that the PBMs have painted themselves in a very dark light through some of their business actions, and I think that's probably saying it loosely. Really, the goal of the PBM is to garner as much income as they can from the pharmaceutical manufacturer. So that is the green line coming from the top box into CVS. They want to pay as little as possible out to the pharmacies. So that's another green line going down. And they want to charge clients as much as they can, which is essentially Blount County. That's the PBM business model. The PBM holds contracts, essentially you're seeing three, simplistically viewed here. One with the pharmaceutical manufacturers and how much money that they will get for the market share of drugs that they push via the formulary. That's a topic of discussion that really is not pertinent to today. But they do hold contracts with retail pharmacies. They'll either do that in aggregate with very large retail pharmacies, or they will do it through a PSAO, which is a contract that they hold, which that contract then services many different independent pharmacies. Moving up the chain, CVS will hold contracts with its payers, in this case Blount County. Now that payer could be anybody. It could be a county government, city government, commercial plan sponsor, Medicaid, Medicare, and those contracts are then dictated how you will pay for the services that are rendered. There's also, in your instance, another intermediary on that side, and that's Employers Health. So Kelly Donato can speak to that when we get there. Kelly's a representative from Employers Health, and in essence what they serve as is a group purchasing organization for plan sponsors like yourself, very much like it's difficult for local independent pharmacies to gain volume and leverage with big PBMs like CVS. They have to go through the PSAO, similar to Blount County. For Blount County to go to CVS directly and get a contract, Blount County is too small to do that. You certainly could, but the rates at which they would have to charge you, their profit per script that they're going to try to get, it's not going to be advantageous. So in essence, you're purchasing a contract through a larger entity, which is Employers Health, about $1 billion.
So, and I was going to jump in, thank you, Mike. So to Mike's point, we have a group of employers such as Blount County, and we have approximately 160 that have come together and purchase CVS. So, for example, I looked at our pharmacy spend last year. Blount County had a little over $5 million in pharmacy spend. So to Mike's point, you would be negotiating with CVS as a $5 million size company. That's your spend last year. We are negotiating with CVS as a $1 billion spend, because we have pulled together a cluster of employers, about 160 right now, and that grows on average about 24 each year. And that is how we are actively negotiating with CVS every single year on the behalf of all of our employers that participate. And one of the things, the benefit of the group purchasing is that traditionally, if you would go direct to CVS, as in Mike's example, you would commit to a 3-year agreement with them. With us, we are actively looking at the contract and the discounts and the pricing year over year and negotiating with CVS to continually improve the contract, the rebates, and the pricing. If Blount County was independently having that conversation with CVS, you would really only be able to do so every 3 years. So typically year 1, your pricing would be pretty jazzy, very competitive. Year 2, a little more stale. By year 3, completely uncompetitive in the marketplace. So that's one of the benefits that we are able to, one, negotiate with CVS for Blount County as a $1 billion size employer, but also internally our legal team is negotiating every single year to improve our contracts, which comes with the improved pricing and rebates that we have actually given back to Blount County year over year.
Thank you, Kelly. So what we wanted to bring to this meeting was a good understanding of what that relationship looks like from CV stream to Blount County. What we do not have visibility into is what CVS is doing downstream. We can certainly speak to the contracts that are held, contend that the rates are market competitive, firmly believe that our recommendation 3 years ago was the right recommendation. We're proud of the county's courage and patience to go through that implementation, and believe it was the right thing for the county from a financial and taxpayer standpoint. And again, certainly empathize the position downstream, and I'm glad we're having this meeting to discuss through it. Before I jump into some of the financials of that decision that was made, are there any questions or comments about what we're seeing here?
I have a couple if I could. In your GPO, have you had this conversation from anyone else with the concerns that we're bringing as far as the very, very low reimbursement?
Honestly, no.
Okay.
You're the first, and when this meeting was brought to our attention last week, I had spoken with my leadership. And to this extent, no. Certainly, we will occasionally hear from some of our other employers that, oh, we have found that this location, specifically for folks that have to pay full out-of-pocket price till deductibles met, this pharmacy is cheaper, this pharmacy is more expensive, and a little bit more of the original conversation around the different contracts that the pharmacy benefit managers have with locally contracting. I think we see it more in our employers that have the true high deductible health plans where consumers
They're paying out of
have
pocket.
an elaborate amount where
Yeah.
the individual consumer has been educated. They know it's such a process with drugs. They change every day. So today I can come to your pharmacy and pay, $10.67, and tomorrow it might be $9.28. High deductible. So I think we are educating their population in that given scenario. Consumers are finding if they're able to obtain their drug at a lower cost elsewhere, and they're constantly looking at that as if I'm looking to buy a car. I'm constantly looking if there's a sale, right? But I think we've not heard the level. It's a high deductible health plan. So I think this is the most we are hearing within our basis. Cole and Carrie might have a different experience with their clients, but I think this is just more of occasional conversations and educating people compared to where we are today with our conversation here.
And I'll comment that this is something that we see nationally. So we have groups that are not with CVS, we have groups that are not through Employers Health, and for our commercial clients, even some that are not city or state county governments, but commercial clients that have been approached by local independent pharmacies in different states with very similar issues. So again, agree with the points in the article that was shared this morning that this is a national issue, and the squeeze on independent pharmacies has been quite profound. So.
The only thing I'd like to add on this too, because I think it does, as you all already know, but I think it's good to have out there in the public forum. We at CBIZ, we're fully independent from this process, and I think that's one of the advantages we gain by not having our own PBM. There are brokers out there that have their own PBM, and then you have the impropriety of, okay, you're steering a client to your own PBM. We are completely unbiased in this process. We have no gain whether you use CVS Caremark versus ESI versus Catamaran versus any independent smaller PBM that's out there. When we did this review process, we did look at other PBMs, and CVS, as Mike mentioned, through Employers Health was and is, I think, still the best option. One of the other vendors that has been mentioned, we reviewed, and there are some big reasons why they weren't a good fit at the time whenever we looked at them previously. And in doing a look back, the percentage discount is significant in the difference. To give you an actual dollar sense, I believe it was a 7% differential in discounting that you all receive through Employers Health versus one of the other vendors that's been mentioned. 7% on $5 million of spend is significant. It's close to $800,000.
It was actually, so what Cole's speaking to is during the bid process in 2015, so when we were looking at calendar 14 data from the county, vendors will they have to send in the specific bid sheet, but sometimes they'll send ancillary information as to what they believe their network would perform at. This particular vendor had sent in a sheet that said that their network performed in aggregate across all drugs That's 47%. Discount off AWP. And for those that are not in this industry, think of AWP as like the MSRP of a car. It's the list price that everybody has access to, whether you're on the consulting side, client side, pharmacy. 47% discount off that. Currently, you're achieving a 53% discount. That 7% on 11 point something million dollars is about $800,000 of how you're performing versus that other particular vendor.
When he says 11 million, I said 5 million because that's what your overall actual spent. The gross cost was 11 million for the pharmacy spend.
Correct. Do you want to show this? The third PDF.
So you said gross was 11, so 5 million is post rebate?
So this is, let me bring up the exact numbers, so I'm
It's
quoting them.
post rebate and discount percentage.
For 2017, the gross AWP for all claims was $11.7 million. So the undiscounted gross costs, the discounted ingredient cost, member paid and plan paid, so the actual ingredient cost of the drug for all pharmacies, all drugs, was $5.5 million. So a 53% discount.
So you're getting 6 on the rebate then?
This wouldn't include the rebate. This is just the strict discount off AWP. So the rebates would be in addition to that.
Oh, okay. Let me ask you another question
Yes, sir.
before you move on. When your GPO signs a contract on behalf of the county or any client, those rates that are established, are they fluid or are they staying until the next contract?
So we negotiate 3 years with CVS, and we also have a relationship with another PBM, OptumRx. And so the same process applies to them. We negotiate this every single year. And so last year when we negotiated 2018, we negotiated for 18, 19, and 20. So we always have 3 years of what the discounts and the rebates will be ongoing. This year, we are actively negotiating with CVS and Optum. It's called our market check. When our legal is negotiating with CVS for this given situation, we have that finalized around late summer. And then what we do is communicate back to each of our plan sponsors, which they're called, so in this situation, Blount County, what for 2019 the improvements will be. In terms of pricing, rebates, contract provisions, and they sign an addendum that they agree to the new pricing for the upcoming year.
So those are set for 3-year contract, set for a year each.
Correct, and
Okay.
so each year we improve that. So the 2019 pricing that's in place today will actually improve next year once this market check is finalized.
Okay. So the bill per se that the county has charged, you know what your bill's going to be every month, right? It's contracted, you know, well, it's based on
If
claims
utilization
data.
would stay, if
Yeah.
utilization for May would stay the same for the next, 7 months, absolutely, you can predict
Right.
that. And, I mean, we're, between the CBIZ team and my team and CVS, we can pretty much predict cost and rebates
Right.
as an estimate for the county.
And as you can see, the literature I gave you, my contract hasn't changed. But my rates have significantly. My ability to purchase hasn't changed, very little. But I see a downward pressure. And because of all this proprietary language that y'all see on your end, that y'all see on your end, nobody knows this is happening until we have this meeting. You look back in July, we were making $7 a prescription, which doesn't even keep our nose above water. I didn't come to any of you with it. It was when the thing went underwater. I mean, that's of great concern. And I don't know how, I guess to some extent, I would challenge you because of the access you do have to get to the bottom of why they can have such a practice and can institute such egregious cuts. And unless we tell y'all, you don't know. You think it's business as usual, and we're over here laying people off. And that's wrong. That's wrong in a lot of ways. And for us to know that there are other plans through the same PBM that are paying a decent rate, and this plan is so bad, there's got to be some answers to that. And I'm not saying it's your fault, but you're the kind of the middle people that are going to have to do the representing to ask the questions. Because I'll guarantee you, if you ask for claims data, you're going to have a fight on your hands because they're not going to want you to see it. I've asked the question. I've had the phone calls on my cell phone from CVS lawyers wanting to know why I was asking questions. I can tell you some stories because I know how ugly it can get when you challenge these companies because they're big and they have money and they own the industry. And I'm probably wasting my breath trying to fight it, but this is my livelihood. Us and our 80 employees, and doggone it, this has got to be fixed. Excuse me.
Yeah, again, empathize with the position, and we feel the same way. I would love to see the data that you have. So we actually have a fairly good data set for the county and can see our costs. Actually, when you mentioned the 54.8% zero paid, I quickly looked. We have 47%, so it jives pretty nicely. We have a different data set. So there are 47% of the claims that the county paid nothing on. But I mean, to think that the county saved this much money, this is what's going on in the back of my mind as a consultant. Here, the county was in a fairly poor deal under Humana for pharmacy. The money was sitting in Humana's pocket. And now as we sit here in CVS, the county is doing very well from a market competitive standpoint in their contract. And as I think through this, that CVS is still making money. That's still profitable business to them. I mean, I would love to see all 66,000 claims next to your ingredient cost to see what that is.
Yeah, so would I.
And I mean, for those that, again, are not in pharmacy in this room, the contracts are generally written in aggregate. So the PBM will say, client, will give you 16.5% discount on all, give you a 80% discount on all generic drugs. There might be one generic that's a 20% discount. There might be one that's a 99% discount. There may be one where they bill the county $100 and pay Mr. LaFoy $5. There may be one that they bill the county $100 and $200 and lose money. But in aggregate, those are the guarantees that they have to meet. So you sit in a competitive contract and can say that's sitting on our side of the fence. I can't speak to what the contract looks like on the other end and the squeeze that's going on in that area, but can comment the fact that that's something we're seeing across all PBMs. It's not just CVS, and it's something that we're not just seeing here in Tennessee. This is something that we're seeing nationally. Squeeze of larger PBMs on smaller independent pharmacies. PBMs buy up smaller PBM. So as Envision buys MedTrack, and buys Envision or buys Rite Aid Envision, this consolidation, CVS buying Aetna, is only hurting the small business owner even more. So I'm not trying to deflect this off the county, but I think what we're talking about here is much more global about the consolidation in the industry that we're seeing. So now that we have Optum, ESI, and CVS owning the majority of the market share,
It is global, and I see the pressure, but I have no plan that's as bad as this one. This is the worst plan I have by far. And when the TeamCare rate, TeamCare at least pays us the cost of the drug plus $8. We're not even getting a dime toward the cost of the drug through this plan.
I want to ask committee members, anyone have any questions? This may be a time to ask a question. Michael?
I'm listening to what these gentlemen are saying, and while it's my duty as an elected official to take care of Blount County, and those employees are part of that county, but so is this business. I'm embarrassed that you're taking a hit like that, and I don't blame you all. I've dealt with this group considerably, and I have a lot of trust in them, and I will maintain that trust in them. But to hear that, in essence, we're putting you out of business That's a big pill to swallow.
Yes, sir.
So I'm, question-wise, I don't know what to ask. But I know to ask this, we're gonna have to figure out what's going on and do what we can as a, I don't know if it's fixable or not, but we cannot put our burden on select discount pharmacy. I just can't see it.
Commissioner?
Cole.
One of the questions, Mr. LaFoy, that you asked earlier, and I don't think we directly answered it, is on the drugs that you receive no reimbursement on. Does Blount County still pay for those drugs? And Mike went through the data. You all do not pay for those drugs that they get zero reimbursement on, so there is a no cost.
That's good
So-
to know, because I didn't know that.
Yeah, so I wanted to make sure that was out there on that part.
So, I mean, again, I think we've all agreed on the problem, but, you know, back to the solution. There are several things that the county could do. And again, we sit in a unique position since CBIZ is not beholden to a particular PBM. We're not paid to place business with a particular PBM. We actually have some hospital clients that have their own pharmacies internally and have negotiated their own business relationship with their pharmacy, and we contract a PBM to pay whatever rates. You know, in speaking with some vendors off the record, they've flippantly said, you know, we can pay a pharmacy more money. I mean, if that's what a client wanted to do, if we wanted to reimburse, whether it's through a dispensing fee or a higher margin, that can certainly be done. But again, that now sits at the county's discretion on where we want to give, where we want to take, where's that money coming out of. You're in a very unique situation as a plan sponsor because you're not only looking out for your health and welfare fund, but you're also looking out for the local businesses and taxpayers in your constituency. So we can facilitate any type of analysis that you would need. We would need the data from all parties, and that's where even those PBMs that exist out there that say that they're transparent, interestingly enough, the one that's been named in the last meeting and the one that we're going to show here real quick, when you look at their response to our bid specification, which is, if you're truly transparent, PBM, we want you to share with us or the client, upon request, your contract with the local pharmacy. So if I'm paying $5.86 per claim, I want to see that contract. And there are very few PBMs, and even the ones that used to say yes to that are starting to not, where that's proprietary information. So they'll tell you that they're going to pass through. So if we pay the pharmacy $5.86, trust us, we'll charge you the $5.86, but we want to see the contract. To us, that's true transparency. We can see the contract downstream. We also ask for the contracts to manufacturers as well, because there's quite a bit of revenue that comes from the pharmaceutical manufacturer into the PBM. We'd like to see what those dollar amounts look like as well. So it's not just saying in a bid or in your marketing sales material that you are a full pass-through PBM. We need to see that in the contract, that you're willing to share the contracted discounts. Yes, sir.
Yes, Phil.
Have we seen, since July, what are the trends on the expense of the plant on a monthly basis? Has the expense to the county been consistent? I'm just curious, since our reimbursement rates have dropped, if you've been charged the same all this time, somebody's got a little extra money in their pocket.
Those contracts are negotiated annually, so I think to Kelly's point, since you can basically...
So it's pretty smooth.
Well, there's two components to this. So when you say trend, there's also the utilization component. So we know as we go on throughout time, the cost of brand drugs goes up, just as a fact in the industry. So the price of insulin, every 6 months, the manufacturer raises the price. Generics can do both. Some go up, some go down. The plan can pick up more people on drugs as we see indications expand for specific drugs. It may come out for rheumatoid arthritis, and then next thing you know, it's approved for ulcerative colitis. That's more people using the drug. So trends may go up over time, but from a discount standpoint, those discounts have improved over time. So the rebates have gone up, the discounts have improved. Back to that supply chain item up there, and usually where I do my finger pointing is on the drug manufacturers. everybody in that supply chain wins when prices go up, except for the plan sponsor and the patient. So as I raise prices, I can offer deeper discounts, I can offer bigger rebates, all the middlemen get paid more throughout, whether it's the wholesalers, the PBMs, and who's left paying that bill? I mean, unfortunately, the worst case scenario is the uninsured patient that comes to your pharmacy and needs to pick up an EpiPen, and it's $600-700. It was interesting when we heard that in the lay news that it's $600-700 when we know there's probably a $300-400 rebate on that, and then there's copay assistance programs out there that kick back some of that. This money behind the scenes is fueled by the drug inflation, so everybody wins. But in that, we have seen the discounts go down. So it's kind of an interesting balance of financials.
We don't always win there. The PBM, when you have a market increase in price, they will sit on price.
Mm-hmm.
They will not move with the market. So we eat the increase for 2 to 3 weeks on a price increase. So it's not like we're putting more money in our pocket.
Mm-hmm.
And also back to, especially with generics, sometimes we never see movement on generics.
Mm-hmm. Is it worth going through the financial analysis that was presented to the county 3 years ago? So this kind of gets to the point as to why the decision was made. Yes, sir.
Don't want these gentlemen to think that I'm getting up and leaving is because I don't care about what they're saying. It's just that I'm on my lunch break.
You have a life, and a job.
I'm very committed to my position on this committee, and I'm very committed to being a county commissioner, but I also do have my livelihood. So please do not take this, that I do not consider this important, because I do.
No, sir.
Okay.
We appreciate your
Thank
comments.
you. And thank you. Appreciate you.
So
About 5 minutes, so I do apologize. If we still have a quorum. Okay. Good.
thank you, commissioners.
They've got it too.
So again, in the essence of information sharing, so to give the folks in the room a little idea of the decisions that were made 3 years ago and why, what we're showing is a blinded example of the financial analysis that was completed by CBIZ on behalf of the county. A lot more goes into what you see here than just the financials. The discussion filters around formulary disruption, clinical programs, member services, mail order, performance guarantees, but since this conversation is really driving around money, we're going to show what we had here. Perfect. Let's leave it here for now, and then we'll scroll to the right. But in essence, what we do is we take a client's base data. So we're actually working with a client's specific data, their specific utilization. Now that we have drugs that cost $100, $200, there's even drugs that have been recently released that are $600,000-700,000, just one patient on one drug can drive a lot of this analysis. But we're taking that specific utilization during a time period and projecting that forward into the future. So in essence, what you see in that first column is Blount County's actual experience, pharmacy-wise, the 2014. So you see the $5.8 million, that was total gross cost, that's total pharmacy spend. There was just shy of $1 million worth of member cost share. That's the actual dollars that members were paying in their copay or co-insurance, which gets to a net claim cost of $4.9 million in spend. The county also received just shy of $90,000 worth of rebates, which means the total expense to the county for the drug plan was $4.8 million. If we scroll over to the right a bit, what we do is we take the bids that were received and the aggregate discounts, the rebates, everything that comes in from the vendors. And not to belabor the point, but what's said on paper is not necessarily what's true, and there's a lot of games that can be played within the PBM industry to make a number look different than it probably is. And I imagine you probably see some of this similar in your contract as well. What's in, what's out, what can we move around to make the numbers look better for us? We make adjustments for that on our end. So something as simple as one vendor calling a drug a brand versus a generic, I can artificially make a discount look better. We correct for those and give true credit where it's due. So during this process, we had showed, I'm going to try to get it up here so it's a little. During this process, we had looked at 3 carriers and 6 standalone vendors. So back in 2014, Blount County had what we would call a carved-in pharmacy benefit, meaning that the carrier, Humana, was also the PBM. At the time, we had looked at 3 carriers in total for the county because the medical piece was also out to bid. And then we looked at 6 independent PBMs. I'll share with you that PBM number 5 is what you are in today. That is the Caremark option. So what you're seeing here, you can compare the experience projected column, which is the middle gold column on the left, which is in essence what the county would have paid if you did nothing. If you would have stayed in the contract you were in, received the same discounts, received the same rebates. All the way to the left, sorry. So the experience projected, there you go. So with the same level of discounts, adding trend, and the same level of rebates, we would have anticipated the county would have spent call it $5.6 million for the pharmacy program. If we scroll all the way to the right, under PBM 5, the costs were 4.2. Interestingly enough, when we went back and looked at this to test our model, because again, this is just a model. This is our best guess at a crystal ball of what things will look like moving forward. It's usually not this accurate, but we were actually within a couple pennies of what the client actually spent as far as a PM basis, normalized on members. So there's $958,000 worth of savings to Blount County's Health and Welfare Fund. You'll notice that the vast majority of those dollars actually came from the additional rebate revenues. So make sure we don't walk away with that $1 million was coming off the back of pharmacies. About $700,000 of that is coming off of pharma, essentially the money that was paid to Humana that wasn't necessarily shared back with the client. The majority of the money is actually coming back now to the county in the form of those rebate checks. And there was a modest decrease in ingredient costs, the actual gross cost. So that's the discounts getting better. Maybe the brand discount going from 14% to 16%. That 2 points over the data is where we're getting the additional ingredient cost savings. I'll pause there, but just wanted to give a little color as to the data that we had at the time and the decisions that were made. If there's any comments, questions, thoughts. And again, by no means am I saying that CVS is the best PBM, but at least as far as the data that we had at the time, it was financially the most advantageous way to go.
So show that PBM 1 again, please. Not good. No, it's good. Yes. So did we take the low bid?
You did not. So
Okay.
PBM number 1, like I said, when we advise clients and clients go through this decision-making process, it's not all about the money. So the county actually took the second lowest PBM. PBM number 1 was mandating a 3-year contract, which we do not advise clients to go into for the very reasons that Kelly mentioned. Locking oneself into this, oftentimes a PBM will offer numbers in year 1 that will look very, very good. Client will jump into it, and then they wake up in year 2 and 3. The rates have diminished on their end, the client's overpaying. So it was worth taking less savings day one to ensure that we had that market check in year 2, year 3, year 4, every year to ensure that the market stays up to snuff. There was also considerably more disruption from a member standpoint and formulary with that particular PBM. And that PBM is not the one that was mentioned at the last meeting, a completely different one of the big three.
Okay, and PBM number 6 looked pretty close as well. Are there other factors on that one?
Yeah, I'm cautious to mention names of vendors here. It's a public bid,
Sure.
so I imagine a lot of this information's requestable anyways, but PBM number 6 is actually Employers Health other PBM partner. Employers Health contracts with 2 PBMs, Caremark, CVS Caremark, and OptumRx. At the time, the way the rates stacked up for Blount County's utilization, the CVS Caremark option was a better financial option.
Thank you.
Another point we'd like to make on behalf of the county, there's been a couple recommendations that we had brought to the county. I mean, as we took on the account and we're scrubbing through contracts and scrubbing through utilization, there were a couple areas that we generally recommend to clients to consider as far as we would say, best practice in benefit design. I'm going to talk about 3 of them, and these are 3 things that the county has not implemented for very similar reasons that we're discussing here. One of which has to do with formulary. So Caremark actually has another drug formulary as far as what drugs are covered, what's preferred, what's non-preferred. There's a more restrictive formulary that the county could take. This doesn't really have direct impact to pharmacies, so I'll make this one brief, but if the county were to select that, there's potentially an additional $300,000 to $400,000+ in savings to the plan if we ever wanted to go down that path, and that's certainly something that we will continue to discuss. But the 2 I want to talk about that the county has not gone down the path of, one being exclusive specialty fulfillment. So this is the notion that folks on specialty medications, and these medications are defined by high-cost biologic medications, medications for very rare debilitating disease states, so think oncology, multiple sclerosis, HIV, rheumatoid arthritis. These medications can cost $5,000, $10,000+ per month. It's best practice in the industry to have those medications filled through a specific specialty pharmacy. There's commentary on both sides of the fence, pros and cons of doing that. From a financial standpoint, it generally makes more sense for a client to have those medications mandated to be filled through specialty pharmacies, which would mean a Blount County member would have to mail their prescription in to CVS Specialty Pharmacy to have it fulfilled. Today, the county does not have that in place. So the county's members can fill those specialty medications wherever they want. That does not take utilization away from local pharmacies. In addition, CVS Caremark has other channel management strategies. I'm not able to share the numbers, unfortunately, in a public sector, but I can tell you definitively that for the county, it's actually cheaper to fill medications through CVS retail pharmacies and mail order, as far as the discounts themselves. Today, the county has the most open benefit that you can have. Their members can go wherever they want. Despite it saying CVS on their card, which is the PBM, member can go to any pharmacy in the national network to fill their drugs. The extreme on the other end would be to mandate that all members must fill maintenance medications at CVS retail pharmacies or mail order. That, if the county were to do that, that's potentially an additional $250,000+ in savings to the plan if the county wanted to go down that path. We generally don't recommend that. It's pretty disruptive to the membership. In addition to some of the concerns here with local pharmacies, we wouldn't want to take that business away from local pharmacies. And we can think usually 55 to 60% of drug claims are maintenance drugs. So they'll be taking 60+% of claims away from local pharmacies that would have to be filled at CVS. So I just wanted to also point out some areas that we've not taken action to ensure the viability of local business.
Did you ever consider recommending Blount Specialty Pharmacy as a provider for the specialty medication? Therefore, you would not have to use mail order. You could come up the street and get it, which on April 13th was sold to CVS because they were putting us out of business. Was that ever a consideration? That you say you didn't want to be specific and put them at the CVS pharmacy because you wanted to avoid mail order. We had a pharmacy right here in town.
My question would be then, would that also take away from City and Lowe's and the other local
City and
pharmacies?
Lowe's didn't have a specialty pharmacy.
Okay.
We're a URAC accredited specialty pharmacy. We were a regional provider.
So
Again,
as the benefit design set up today, and correct me if I'm misspeaking, but you should be able to fill those specialty drugs through your pharmacy.
he wants it exclusive.
An exclusive.
Contractually,
I'd
they
look
make
to,
it.
I believe under the contract we're under today, we couldn't make another pharmacy exclusive. It's either CVS exclusive or everybody.
Okay, I was just curious because
But-
we could avoid mail order and could have done it right here. And the point to be made also on the three options there, the one you said that you'd stayed away from formulary, just to be sure all of you are aware, when you restrict the formulary, how you arrive as a PBM at what is and is not on the formulary are the drugs that carry the higher rebate from the manufacturer. So the manufacturer is paying the PBM for position on that formulary. Yes, you would get savings, but that's what drives that. It's just more of this big money changing hands, and part of it will trickle down to you. But the most of it stops at CVS. Correct?
Very, very fair statement. So there's an interesting balance between promoting brand utilization to get a rebate, and when we think about what a rebate is, it's a refund for an overcharge. You've charged me too much money just so you can give something back. So we encourage clients not to chase rebates, but where it's appropriate, or in drug classes like insulin or inhaled corticosteroids where brands are the only option, sometimes it does make sense. If I have to pay the $200 for a vial of insulin, if the client can get back some rebate for that, sometimes it may make sense to do it.
And that's what drives mail order. They have a pharmacy, they have mail order pharmacy, they have a PBM. They can drive rebate dollars into their mail order facility and drive costs down. I don't have access to that.
And to reiterate, you all are currently in essentially an open formulary and a very open access type of plan. So you all don't have those limitations. And thus being the reason why you all chose not to go that route, and why we would be very hesitant and fully recommending that.
Committee. Does anyone else have any questions? It's a lot of information. I want to thank everyone for participating. We'll take this under advisement and try to see what can be done to help our local people. Appreciate y'all coming. Appreciate everyone acting appropriately. So, yes, got a question here by the mayor.
So this, and I'm going to try to simplify this to where I understand it. The pharmaceuticals who distribute the drugs now is there someone in between the pharmaceuticals and you that you buy the drugs from? How does that change?
I buy from a wholesaler.
So if CVS or Walgreens or Walmart, or do they give them a different price for those drugs than if they're buying with huge buying power? Can they buy the drugs cheaper than you can buy the drugs?
Yes, sir. Well, I mean, volume drives. Plus,
How can it work that way? I mean, it's not a level playing field. If you're not buying the drugs, if Walgreens, CVS, Walmart, Costco, whoever's got those chain pharmacies, the huge pharmaceuticals, pharmacists are buying it less than you are buying it, they're buying it with a buying power that gives them the option to buy for less than you do. It's kind of like trying to have a grocery store or a car to sell tires or anything. When the big boys come in, if they're buying the stuff from Michelin and Goodyear, or they're buying the groceries and everything at such a discount price that at the local level it puts you out of business. Is that in the essence, is that what we're looking at right here, is what's going on, Phil?
yes, sir. What we're driven to is become a volume proposition, but it's gone so deep now, we've had to really become students of efficiency and try to be as absolutely as efficient as we can and try to outserve, if you will, the big box. Try to provide exemplary service, exemplary care, hopefully to drive the volume to be able to pay the people that we employ and stay in. And it's just becoming a greater and greater challenge. I mean, just like the article that I sent y'all. I mean, that's what's going on. They all own drugstores, and we're in the way.
The one comment, and Mayor, you made a comment at the last meeting. I was listening on the video but wasn't able to speak about Amazon coming in and taking pharmacies. And as a pharmacist, it would pain me to ever see that. I unfortunately think that in our lifetime that may become a reality. And as a practicing pharmacist, having worked with independent pharmacies before, having wanted to own an independent pharmacy when I was in pharmacy school, it's challenging to see people treat healthcare and treat the delivery of drugs like a commodity. But unfortunately, whether it's the patients themselves moving prescriptions to get a gift card at Target or get a gift card at Walmart or to save $5 on a copay, human beings have treated pharmacy like a commodity. The county has chosen to purchase their pharmacy benefit manager in volume like a commodity. As a plan sponsor, you can absolutely make the decision to go another route. But again, that will come with costs if we wanted to do that. But I mean, as your advisor, we can take that. As you take it under advisement, if there's something that you wanted us to take as far as an action item, we can. But I think you hit the nail on the head of exactly what's causing a lot of the angst that's driving this conversation.
Stop. I mean, when does it get to the point that you can't, that we can't afford to? I mean, is the goal for local businesses not to be in the business anymore, Phil? What do the pharmaceuticals want to see?
That's our field. I mean, we see fewer and fewer independent pharmacies every year. We've been blessed with a good business and a good client base, and we feel like we may be the last one standing, but we actually can look in the future and feel like that's maybe not too far off, just because of the pressure, you know. And there are so many of the big boxes, and you know, you may want Walmart, Walgreens, CVS. That's the thing. When you've just got 3 or 4 standing, your cost is going up. You know it is.
Thank you, Mr. Chairman. So just in black and white here, help me understand, or let me make this comment and see if it's close to accurate. This is fixable. Someone will bear the burden. County employees, taxpayers, ultimately everybody. And I'm not sure what the answer is. I'm all about shopping local, and I preach that every day. So I don't know how to fix it, but I think at the end of the day, it's not really Blount County that's hurting you. I think it's the big box stores. But how we get there, I don't know without penalizing employees and the taxpaying citizens.
Well, and in the bigger picture, I mean, this sounds like Walmart at the local level. This is where we used to be before Walmart was here. And along with Walmart comes those buying discounts, and offering to the public all of a sudden becomes a cheaper price. And so volume of people will go where the price is. So is this any different than that I can see?
It's the same concept.
Same concept, but when you get back to what brought us here, from July till now, I'm underwater and nothing has changed except how much they're paying me. Somebody's putting more money in their pocket. I'm not saying Blount County, I'm not saying CBS, I'm talking about CVS, but they have plummeted in what they're paying us with no explanation. When this thing dropped October 25th, they turned off the pipeline we had to appeal prices. We couldn't get them on the phone. We couldn't get anybody to talk. They just went radio silent and cut our throats. And y'all kept paying the same. Everything was the same except what they paid us.
And good. And what you're saying is you can't do anything about this. And what you all are saying is you can't do anything about it. So Commissioner Kaler earlier asked a question, what is the problem here? And can it be solved at this level? And what it sounds like to me is the problem is above where you all are negotiating these contracts. So how do you fix that? Because if it's an issue we can't fix at the local level other than for us to write a bigger check to solve a problem that's above our heads, doesn't make sense to me. If you can address the problem as to where it's occurring, and if that's between the drug manufacturer and that next level, I don't know where that is. Talk about that just a little bit, because we can sit here and agree we have an issue all day long, but unless we can go to the level it takes to solve the problem, then I don't know what the county can do.
So I think, again, agree with you that we all agree on the problem. There are solutions, if that's what we want to call them. So kind of two knee-jerk things that come to mind. Under the arrangement that you're under today, we'd have to reach out to CVS to see if they could administer this, but the county could certainly offer to pay Blount Discount Pharmacy or any other pharmacies of their choosing an additional fee. So that money can come out and be paid to make whole, and that would be determined how that would be done on a business level. Additionally, the county could choose in the future to contract with a different PBM, but again, during that RFP phase and during the contracting phase, it's going to be between the PBM and Blount County. Anything that PBM, even if it's the new PBM ABC that goes effective 1/1/2020, we have no control of what that PBM chooses to do with their network in the future as well. So we may be just kicking the can down the road to select a PBM that has looser rates in the market, but as they continue to ratchet their rates down to maintain competitiveness, we may see ourselves in the same situation 3-4 years down the road, depending on what the PBM industry looks like. So there's routes we could go through. You can dictate what you want to pay for the drugs. As a self-funded plan sponsor, you can pay whatever you want. I'm confident that you're in a very, very good spot today under the contract. If you were to look at a new PBM, it is very likely that it's going to cost the county more money, significantly more money. But those are your choices to make. And again, we don't have a horse in the race. Our compensation is not tied to CVS or Employers Health or that.
I guess my question would be back to your two options are going to cost the county money. And I keep going back to, you said question the PBM. I just want somebody to ask the PBM, why all of a sudden did you slash rates? With the market being stable, we're paying the same price for medication. I want somebody to ask the question, why were the rates cut?
And that's a
I've
question.
tried.
We can ask that question, but that question has to come from the other side. So that would be a question from the pharmacies or your PSAO, and their lobbying power to say, whether it's on a drug-by-drug level here or an aggregate, and telling
And
them.
my PSAO corporate has met with CVS corporate, and that's why you see one of my graphs, you see profitability tracked up over the last 3 months. So over the last 3 months, I'm actually almost making $1 a prescription. You know, the minus 08 is like over the last 8 months. So that they've responded, they're paying us $1 now. But we have asked the question and gotten very, very little response.
I do. I don't know if this would be a Randy question, Jenny, whatever, but if we did start paying more money to your pharmacy, the city drug, and all that, so that's money that the county is enduring. Are we going to pass that along to the employees? Are we going to have to do a tax increase?
Can I?
What, you know, is there a win to it? I mean, somebody's going to have to pay, and, you know, burden put on our employees because we're finally getting them to a standard that, and I hate to just keep going back and saying, okay, your pay's being cut again because of this or that. I don't know the solution.
Yeah, so, and that brings up a good point, Phyllis. So your current program, you have a flat $10 copayment for generic drugs, but for your preferred brand and non-preferred and specialty medications, the employees pay a percentage of that cost up to a maximum amount. So for generics, the employees would not pay any more. So that would be no different. For the brand, if it's less than those thresholds on the maximums, like I believe, and I'm going from memory, your preferred brand might give you, it's a maximum of $60 that they pay out, and then non-preferred is $100, and then specialty is $200. Man, good. All right. So if the prescription, let's say, was $5,000, they're going to hit that $200 threshold no matter what the, I mean, if it goes up down by $4,000 or up by $6,000, they're going to meet that $200 threshold. Now, if that preferred brand drug is currently $48, that employee's going to pay $48. If that preferred brand drug then goes to $75, they'll cap out of the max at $60. Same with the non-preferred and the specialty. Now, arguably, most non-preferred drugs are probably going to way exceed $100 as it is, but there are going to be some that may not. And so, yes, the employees would feel that.
And also to add on to that, so let's say this change is made and it's decided to move or pay more, and it's going to cost $300,000. Whether it comes out of the copays itself, that's something that our actuaries will have to consider in the capitation rates. So as you're deciding the contributions for employees, it may come out of that, it may come out of other dollars from the fund. So it's going to come from somewhere, whether it's on the back of the employees or taxpayers. That's, again, your decision to make.
So let me just go back to Phil's question from a little bit ago. He says he's asked and can't get an answer as to why the rate was slashed or why the rate's gone up for the last month. Is that a question you all can ask?
We can ask that question, but we're not going to get the straight answer on our end.
What is the answer that we've been given?
So the answer lies in the contracts in which CVS holds downstream. So when CVS contracts those rates, whether it's an aggregate or mechanically on a day-to-day basis, they're using what's called a MAC rate. So it's the maximum allowable cost for a drug on that given day for that given pharmacy. You can think of it as kind of a price ceiling. This is the most we're going to pay. And the intents of it are good. So if there's a generic drug out there that's available from 2 cents all the way up to 30 cents and it has 6 manufacturers available, they need to be setting that rate that's appropriate. So they're not going to set the 2 cents. They may set it at 6 cents or 5 cents that will appropriately reimburse a pharmacy and encourage good purchasing, because we don't want pharmacies purchasing the dollar a pill drugs. We want them buying as cheap as they can in quantities that they can get through before the product expires on the shelf. So the intensive MAC rates are good. However, what we're seeing is those MAC rates are being squeezed to a point where we see them drop below an acquisition cost. So now if the acquisition cost at the pharmacy is 2 cents a pill, but the PBM is only paying 1 cent a pill, the pharmacy loses money. So when those are being set and negotiated, and the process to contest those rates by the pharmacies to the PBM is all dictated in the contract between the pharmacy and the PBM and the PSAO if that's involved.
So I think what Mike is saying is that it's really, while they've recently had some change, I think through the PSAO is going to have more leverage with CVS or more of a direct channel from their end on reimbursements than what we would have access to. So as Mike is mentioning, we can ask the question, but we probably aren't going to we're not going to have the leverage.
Your contract doesn't dictate access to that. And the same thing goes on your end. If you decided, hey, we want to pay more on brand drugs or we want to pay less on generics, the contract that you hold through Employers Health is fixed. So if you wanted something custom, you'd likely have to leave that relationship, have your own contract, spell out what you want to pay. We lose the volume, we lose the leverage, we will pay more if we did that. But that's on our side of the fence. On Bill's side, we can ask those questions all day long, but it's going to take the lobbying of not only local Blount County pharmacies, but nationally, those independents, their PSAOs, to beat up against the PBMs to get rates that are market competitive.
Is that at the state or the federal level?
From what we've seen, it seems to be a very grassroots effort from local independent pharmacies in specific districts, but it's going to be something that's going to have to be done at a federal level.
Because it's something we can't do, outside of deciding to pay more for a plan than we could go out and get it for, in order to supplement a problem that's at a higher level than where we are.
Correct.
Okay.
Right.
Thank
Well,
you.
to your point earlier, you could very well wind up right back where you are because they're playing games with MAC rates. You could very well wind up charging more money. I'm shooting myself in the foot saying this, but it's the reality of it all. You pay more, and they wind up cutting my throat yet again.
And that's likely what they'll do. So if they're paying a cent and we go through all this and all of a sudden they say, okay, he's paying 2 cents, we'll pay 4 cents. If your rate was 9 cents, they're just going to raise your rate 3 cents.
That's my point. We could complicate the problem by trying to solve it in that manner when it sounds like this is an issue that's above our ability to fix. It definitely needs to be addressed and it needs to be fixed, but I don't think it's something that Blount County can do.
I think he kind of touched on it right there. I guess, is it a fair assessment that the problem, the way these folks are being mistreated doesn't lie within this body or Blount County government? It actually lies within your suppliers, your distributors, who need to be more transparent with you and a better way of doing business with you. It sounds like to me. Is that?
No, because like Phil said earlier, we don't get any response. Even at the national level, through our PSAO, half the time we get no response. I mean, it's just like on MAC. You know what MAC is on a drug?
I'm like Commissioner Lewis. How that's facilitated, I don't know. I think that's past this body, but I would sure like to see somebody help you do that.
He had mentioned maximum allowable cost. The PBMs can't even tell us what the maximum allowable cost is on drugs. It just changes. It's a moving target. So when we sign these contracts based on maximum allowable cost, and it might change. I mean, in half the time when we get underpaid, a lot of times they'll say, well, we can find it at another, sometimes not just CVS, other PBMs will call and they'll say, well, you can find it at another wholesaler cheaper. And that might be a regional wholesaler that has it out in California. I mean, and there's just no way. There's no way to know. They're right there.
Yes, sir, Mr. Chairman. I know it's probably not this simple, but could we require caps on the overhead charged by PBM, for example, if the county paid out $100 for a drug and we had a cap of 15% overhead on that, then the PBM could keep 15% and then $85 would go back to the pharmacy of choice of the employee.
So there are PBM contracts where you could do a couple things, and this gets into a transparent PBM model that I was speaking to earlier. So there are models where you can contract with the PBM that you, Blount County, will pay the PBM the same rate at which the PBM pays the pharmacy. That still doesn't get around the MAC issue because the PBM now, they still need to manage that network, they still need to ratchet the rates down. But under that type of arrangement, you could also stipulate in the contract that we want to pay a $1 dispensing fee to all pharmacies except for these 3 local ones, we want to pay them $15. So you can dictate in that contract how you want to pay for drugs, what you want to pay. That's doable. But again, we lose 2 things. We lose the leverage of the coalition, which is going to cost money, and then those dispensing fees that you're now paying that are outside of industry typical dispensing fee on your end is 50 cents, 75 cents. So if you're going to pay a pharmacy 15, and I say this because we have a client that does this, they pay their in-house pharmacy, it's actually $12 per claim. In aggregate, it actually costs the client more money to do that, but they choose to do that to put the money from one business entity to another within their same organization. So again, this can all be done, but the money's not going to come out of thin air. It's going to come from somewhere. So to answer your question, the answer is yes, you could do that.
Well, it just sounds like we're sending in money and very little of it makes it back down to the pharmacy.
But through that contract, like mentioned in the very beginning, you were sending in $98 per member per month. Now you're sending in, as of 2016, $85.81 per member per month. So inevitably, your organization and its employees have saved. Obviously, unfortunately, on the Blount discount in the local pharmacies, if they're saying their reimbursement rates aren't as high as they once were, that could very well, it sounds like that's the case, but unfortunately, if you want it to be higher, that per member per month cost is also going to go up because you are essentially a self-funded plan. So, and CVS, Caremark has much greater purchasing power or power as a whole than a transparent model likely would have. Is that fair to say?
And you could certainly choose to have your own agreement. I mean, the county could come to agreement with local pharmacies of these are the rates we're going to pay. We'll pay you AWP minus this on brands, this on generics, and it is what it is. But those rates will likely be less competitive than what the market could bear. Again, these are decisions that you'd have to make based on the financials of it.
Yeah, with all of this that's going on, is there an oversight committee or is there any, who's watching?
No one.
At the national
Who's
level,
watching
no one.
this stuff?
No one.
So,
That's where the conversations at the national level are supposedly starting.
well, I want to tell you, I'm reading my second book on the rise of the pharmaceutical companies, and which I have to bite my tongue while I'm sitting in this meeting because I'm telling you what's truth. They are probably the largest lobbying body in Washington D.C. and the stories, honestly, with just what they've been involved in and how they've done business politically across this country is kind of scary. So I just wondered if it doesn't surprise me though that no one's regulating them. I can see why that would probably be it just seems like it's something that somebody needs to be somebody that's a lot smarter than I am needs to be watching what's going on with this group, with the way this whole thing is playing out, because the one thing that we've really worked at is to not develop monopolies and develop just one single stream for something that you need in your life. And it looks to me like we're probably 10 years away from this becoming a monopoly, the way they're rolling right now. And it seems like it's unregulated. That no one's pulling the brake on it.
Representative Ramsey, the law that the state of Tennessee passed this year about the having a license, will that help us with this situation, or do you have any idea? Either one, Representative Moon or Ramsey.
Some regulatory ability to at least give us some oversight. Not to be much, and I think the issues that the folks have brought up here, both sides, are very relevant. We're looking at an extremely important issue. Tennessee, for the last 10 years that I know of, has been the highest utilization of pharmaceutical prescriptions in the United States per capita, and that's equated into the situation with the narcotics, the opioids, and what we have to realize is that these folks are providers. They're excellent providers. We're seeing the same issues pop up in medical care with these same pharmacies that are involved in the benefit management are also starting to get other health care, primary care, nursing facilities, you name it, and they're going to, in effect, drive other competitors out of business. We need to maintain, with the issues of pharmaceutical substance abuse and addiction, we need to maintain a very appropriate level of oversight from our professionals, and that's not going to happen when you start forming monopolies. We're seeing it with pretty much all of the healthcare industry. And I think probably the question that you're asking is very appropriate. Who's watching the store? Who's minding the guys that are up here without transparency? And I think that's the job of government. And essentially, that's what that bill was about this year, is transparency. Phil, this is not the first time I've talked to Phil about this, and I'm very shocked that our independent pharmacists and pharmacists in general don't have a relationship with Blount County government. I was very surprised because they're in our faces every day and have been for the last years that I've been involved, and rightly so. And so I would encourage you to maintain this relationship. These guys are very important to your constituency. They're very important to our law enforcement. They're important to making sure that we get adequate provision for medical care. And they're going to be more so all along as we approach medical cannabis and stuff like that. That's going to pop in eventually. But I would ask that you as a team, now that you have a relationship with them, you advocate with state government. We have powers. Several of the bills that I've had over the last 10 years have involved benefit management. And these guys have been under terrible situations where they could just pop in at any time and check their records and had no transparency about what they did and comparisons and anything else. And I think the federal government's interested in monopolies. They're interested in transparency. The state government is. Now that you know there's a problem, include us into it, and we'll because we know what's at stake. Does that answer your question?
Yes, sir. Thank you. One last question, Phil. I can't operate the machine. Services that you provide to this community that the big box stores do not.
Wow. Well, I just think with Blount County alone, we started the smoking cessation program where we partnered with Blount County and just recently put that into play. We offer diabetes training, diabetes education. We deliver medication to homes. We do house calls. We go into the homes. We do immunizations in the homes. We do drug reviews in the homes. That's kind of one of my passions. I always feel like, people are shut-ins. They can't get out. They can't get to us. We need to go to them. And we don't get paid for that. But that's what we do. I've said this too many times. Aaron's tired of hearing it. But people go across the world to do mission work. We unlock the doors to our drugstore. That's what we bring to Blount County. This is our mission. The reason I'm sitting here in front of you today is not because I'm trying to get rich. I'm just trying to be able to pay my people and be able to keep doing what we do. We may be able to, we may not. But if we don't have these conversations, we never find out. But just the level of care. And not to say that people that work in the chain don't care, but some of the work environment that they're placed in, the restrictions because of the help that's allowed, the payroll that's allowed, those people work in pretty tough situations. A lot of those pharmacists, they can't take the time that we have the ability to take to give a patient or a caregiver because they head down and they're scrambling all the time. And our company was built on the idea that we're going to always strive to keep enough the needs of our people in the community. That's what we do.
Real quick, Mr. Chairman, served on insurance and banking this last session. The licensing requirement for PBMs is the first step to address this issue. It really needs, like Dr. Ramsey, Representative Ramsey said, it's a federal issue, but both our offices have heard and people have reached out for us to advocate for them, and licensing of PBMs is the first step because before there was no leverage by state government. Is that an incorrect statement, Representative Ramsey, or are we on target? Thank you. Thank you, Mr. Chairman.
Thank you.
Okay, do we have that written down?
Action to adopt medical rates.
Okay.
1/119.
Okay, that'd be fine. Well, y'all can sit right there if you want to.
Just stay.
Just stay.
We gotta get it done. I mean, sorry, just stay.
Can I
We gotta
turn your
get this
mic
done.
on?
They've gotta go.
Which one is it? Oh, King. The one that says King?
Oh, man.
Okay. Next item on the agenda is the action to adopt medical rates for 1/1/2019 prepared for open enrollment.
This is new.
This is, what'd you say?
This is new, so.
Yeah, this is the new thing that was added to the agenda. I need a motion. Mr. Hedrick
No.
and Mr. Lewis second it. Discussion. Mr. Lewis. I got Mr. Lewis here.
No, I'm good.
So all we did is, as Jenny mentioned, the trend, and you all are actually experiencing some higher claims as of late. You have a really high claimant, and that's projecting to go well over your stop loss amount. So I will say that this is including that we are expecting an increase in your stop loss insurer, because this is your first year under that insurer, and you're expected to have some pretty big claims under that, so that's not going to bode well. Whenever renewal comes up, we won't get that renewal until October. Your overall trend, though, is, roughly, they say 8 to 12%. I believe what's going in front of the budget committee is a 10% increase in the funding for Blount County. We're recommending no increase to the employees, and these are what the rates would look like under that amount. Assuming the employees would pay the exact same, and then the county picking up the 10%, which will keep you on track to make sure that you don't have the issue that had 3 years ago of going downward. We're getting to a point where you're building up your fund to where it's an appropriate level so that you're not going to go bankrupt within the plan. So, thank you.
Yes, I just want to make a note for the committee members. The rates that you're seeing there are under the Blount County column. Because of the way the budget process works, this was the amounts that were included in the budget that the budget committee has seen and has sent forward to commission. So the budget committee has approved that rate. It's included in everybody's budget. It's been built in all the way across the board. So that will be the rate that is before the commission when they vote on the budget. We just have to take the formal process as well here to set that rate so that we get that employee rate, which again is no change to the employees.
On the top part under benefits, what are the changes from our current benefits? Are there any?
No, sir. There's no changes to the employees.
Thank you.
So last year, you all imposed a $5 differential to the employees, where the employees now pay $5 per month for the dental plan. The families have always subsidized the differential in the cost. Your dental rates have been the same since we've worked with you, and actually before then by a couple years. So you all have had essentially the same dental rates for a long time. Your utilization was to where Delta Dental the past 2 years have actually paid out more in claims than you all paid in premiums. So essentially they've lost their tail, especially considering admin they factor in is generally around 20%. So you all should be around an 80% loss ratio. You all are actually around 104.5. So needless to say, they did give you an increase. The increase is typically, for what would be justified under their eyes would be around 35-40%. They did not give that to you. It essentially, it came out to very, on a dollar perspective, not a significant increase. We're showing that the employee rate would remain the same at $5 per employee. The family rate would go up slightly for the family since they cover that cost. Blount County's cost would go from $17.14 to $21.04, and so your total rates are at $26.04 versus $22.14 for the employee, and $69.46 for the family versus $81.68 is where it's going to. I'll tell you, Delta Dental, I don't know if you all have personally experienced it, but we have had little to no issues on any kind of consumer basis, and they're one of the largest networks in the area or in the state. So they've been a very good vendor to work with.
I see no lights. Are the members ready for the question? Ooh, Scott, Mr. Graves.
Again, just making sure, are the benefits the same as they are currently?
Yes, sir.
Thank you.
Thank you, Mr. Graves. Motion to approve, move forward the dental rates for 2018-19. Vote yes to move it to the commission, and vote no to leave it in this commission or this committee. Okay. Mr. Mitchell?
Motion to adjourn.
We've got a couple things here, Mayor, sorry about that.
Just trying to get everybody.
Mm-hmm. See, Mr.
It's announcements.
Thank you, guys. Mrs. Morgan?
Thank you, Mr. Chairman.
No, I'm sorry.
I just wanted to take a minute to tell what's left of the committee that how much I appreciate all of your thoughts and your texts and your concerns. I received numerous calls and emails from you guys after the death of my mother, and I just wanted to tell you all how much I appreciate that and to thank you for that.
Next thing here is public input. Anyone out there that wants to say anything to this commission that's not on the agenda? Yes, sir. Come on. I'm trying to hold the mayor's I'm trying to get him to wet the seat over here. Okay, you got something, Mr. Mayor?
Make a motion to adjourn.
Got a second? Here we go. We're out of here.